Hello, everyone. Welcome to our Thursday webinar series. I'm going to wait just a few minutes for everyone to just get connected and logged on. My name is Lourdes. I'm a patient advocate with the Cholangiocarcinoma Foundation, and we are happy to have Dr. Andrea Cercek here with us today to talk about the HAI pump. Dr. Cercek is a board-certified medical oncologist specializing in the treatment of patients with gastrointestinal cancers, particularly cholangiocarcinoma, colorectal cancer, and appendix cancer. Her research is focused on the development of novel systemic and regional therapies, including approaches based on tumor genomics with the goal of improving outcomes while minimizing treatment-related toxicities. She is a founder and co-director of the Center for Young Onset Colorectal and Gastrointestinal Cancer. This clinic, the first of its kind in the world, is dedicated solely to the specific needs of people under 50 who have GI cancers. Thank you so much for being here. I just want to give one reminder to our community again. Please, if you have questions, you can put them in the Q&A or the chat, but please keep them general in nature, as Dr. Cercek will not be able to answer specific questions. And I will pass it off to you.
Hi, everybody. Thank you so much for the introduction and for having me. And I'm excited to share a little bit of data about HAI, or pump therapy, as we call it, specifically in intrahepatic cholangiocarcinoma, and why we think it's a really important and helpful treatment modality. So I'm a medical oncologist at MSK, and one of my additional research interests is regional therapy, and particularly liver-directed therapy. So just very briefly, in terms of standard of care, for cholangiocarcinoma, so obviously it's a rare disease, as you know. It's about 3% worldwide of all gastrointestinal cancer. So it's about 50,000 or so individuals annually in the US that are diagnosed with cholangiocarcinoma, or intrahepatic cholangiocarcinoma specifically. It's a tough disease to treat, mostly because when it's diagnosed, it's already, although we sort of stage it as an early stage, it's already more advanced. It tends to spread quite quickly. And so it just is a challenge to treat with systemic therapy or chemotherapy alone. And so some of the data, I don't love to talk about these numbers in general, but just most of what we've been able to achieve with combination chemotherapy are small kind of benefits in median overall survival. So that's how much, the median number of people on a trial live with intrahepatic cholangiocarcinoma. So these are combinations of standard of care gem, cisplatin, and nab-paclitaxel. And now the newer study, the TOPAZ study, added an immunotherapy durvalumab to gemcitabine and cisplatin. And with that, we did see a little bit of a improvement in overall survival, but obviously there's tons of room for improvement. We really can and must and will do better than that. And so what is hepatic arterial infusion, and why do we do it? Certainly at MSK, but now actually at more than 40 centers in the US, as well as centers in Europe also. So the idea of pump therapy, sort of very simply, is it gives us the ability to give a very high dose of chemotherapy directly into the liver. And by doing that, we're able to treat the tumors that we see and that we don't see in the liver. So what it looks like, it's this cylinder right here. It's about the size of a hockey puck, maybe a little bit smaller. It sits underneath the skin, but not inside the belly. So it feels almost like a Metaport, except it sits below the ribcage, above the waistline in most patients. And then inside the abdomen, so it's placed surgically, and inside the abdomen, a catheter is basically attached into the gastroduodenal artery, which is an artery that supplies the liver. And then everything is sutured in, connected, closed. And then what we do is we access the pump with through this little septum, and we put chemotherapy into the pump, and then it flows continuously over 2 weeks. So it gives us this ability to give 400 times the concentration of what we can give through the IV because it goes directly into the liver. And what our liver does, actually what its job is to process chemotherapy, to process drugs, to process toxins, et cetera. And so when the liver sees this chemotherapy, it clears it by what we call first pass metabolism. And what that means is that it did nothing, the toxicity of the chemotherapy doesn't get into the bloodstream. So people don't have the common toxicities like nausea, vomiting, hair loss, diarrhea, and what we typically see when we give chemotherapy through the vein. But the liver has to process this very high dose of chemotherapy, but it also hits the cancer cells, and that's the benefit. And so the pump is made of titanium. It weighs a few ounces. The body heat actually enables the delivery of the drug. The top part of the chamber is empty. That's where the chemotherapy mixed in saline is instilled. The bottom chamber actually has gas in it. So this gas kind of on its own just naturally bubbles and basically propels the chemotherapy into the liver. So there's no clicking sound, there's no mechanism, there's no battery, but it just flows like this continuously over a period of 2 weeks. And so that's kind of the idea. That's basically what it looks like. I can show this video, I think, if I can figure out how to show it. That's the chemo, the green going into the liver, and then preferentially going to the tumor cells, because most of the blood supply is actually arterial to the tumor cells. So most of the chemo goes into the tumor cells, but some definitely does hit the healthy liver cells as well. And that's something that we have to pay close attention to when we treat with hepatic arterial infusion. But that's just kind of a nice schematic to show you what it looks like. So here's some of the clinical evidence specifically in cholangiocarcinoma. We use it very frequently for colorectal cancer that tends to have liver metastases very often. But in cholangiocarcinoma, we actually saw really significant benefits with use of HAI in combination with systemic chemotherapy. So we had a significant improvement in overall survival. And this was a trial that I led with Dr. William Jarnigan at MSK. And basically here, everyone received pump chemotherapy and then oxaliplatin and gemcitabine. And we chose oxaliplatin instead of cisplatin, as I mentioned earlier, because of the way that we administer this treatment every 2 weeks. As I mentioned, it flows continuously for 2 weeks. We were more comfortable using oxaliplatin at doses that we were familiar with, and there were earlier studies that showed benefit of oxaliplatin as in cholangiocarcinoma as well. And what we basically saw is we saw a really amazing response rate. We had over 50% of patients having this beautiful response in their primary tumors, and many more than that, over 80% had disease control. And amazing survival of 89% of patients at just 12 months, which is pretty phenomenal. And that tail continued, and people lived significantly longer, as I mentioned, a large proportion over 3 years, and some even now, and the study was done in 2013. And really what we believe is happening here, and why this is so beneficial in cholangiocarcinoma is that the difficulty for a lot of patients with cholangiocarcinoma is the location of the tumor. Can't do surgery because it sits very centrally in the liver, as was shown in this schematic. Often it sits right in the middle. You can't resect important structures when the tumor sits right in the middle, even if there's a really good response, sometimes even when it's very small. And when we gave the HAI therapy in this trial, what we saw is that the tumors just responded and then just kind of froze and sat there and really didn't change much radiographically, which was tough for us to say, is this all dead tissue? Is there still some live tissue here? But many patients, for a very, very long period of time, just had this measurable area in the liver and nothing else. And then at some point, sometimes they developed cancer outside of the liver. And it sort of almost changed the biology, because we treated that primary liver tumor that otherwise would have caused trouble, which we see often with just systemic chemotherapy. When it starts to grow, people develop liver failure, and that's the problem with cholangiocarcinoma. This treatment really in our experience in the study, really patients benefited significantly because they didn't have the complications of the liver progression, because we were able to control the liver tumors with HAI therapy. So we now have a study. There's been a meta-analysis also just looking at other studies using HAI therapy, and there was a significant benefit when we compare our study of HAI in combination with systemic chemotherapy. And so we've actually taken this forward now into a large randomized study. And I'm happy to say it's a multi-center study. It's not only at MSK, it's being done at Duke, the NCI. We are at WashU University in St. Louis, and we are also going to open it in the Netherlands, which is, super exciting that this is kind of beyond the US as well now, being utilized in the Netherlands. They've actually done their own early phase cholangio study and showed very similar results to ours, which is obviously always, very encouraging to see that a study can be replicated somewhere else in another area with a different patient population and have the same impressive responses and disease control, particularly in the liver. So we're very excited about the study. It's a randomized study, but what we hope to accomplish is that we hope to, be able to see that there, whether or not there is a benefit in a randomized fashion. So that study's now actively accruing. And as I mentioned, we're really excited about it. But I want to spend some time today too, just to kind of tell you what life is like with a pump. You hear about it, you see the size of this hockey puck. Is it actually possible for people to have a meaningful quality of life? So as I mentioned, it sits underneath the skin completely. It's covered by the skin. There's nothing sticking out of the individual. Oftentimes it's implanted if there's a removal of tumors, or in the setting of our study and most cases of cholangiocarcinoma, it's placed actually to treat the tumor. And then we do a scan to make sure that the chemo is going just to the liver, because there's all these blood vessels that are involved, and sometimes some of them can kind of clamp up, and we want to make sure that there's no flow of chemotherapy outside of the liver, where we know the liver will process it right away. So that's a scan that's done. And then once the patients recover from pump placement is when we start treatment. And typically for cholangiocarcinoma, if we're not doing any resection, we sometimes start treatment right away, 2 weeks after placement, or sometimes even sooner if there's been no resection done at all. And then we add systemic chemotherapy, usually a couple weeks after that. So patients initially feel the pump a little bit because there is some swelling, there is a bit of weight to it. If the patients are very thin, very small, it can be noticeable. Most people learn to manage it just fine and wear clothing that fits and is not particularly bothersome. But in the beginning, they do feel it a little bit, and there's a little bit of weight to it. So in terms of limiting activity, so I mentioned before that the way that it works is that there's a gas that kind of propels this chemo forward. So we get a little bit particular about activities that might accelerate that gas, those gas particles, and then accelerate the rate of chemotherapy into the liver. Most activities are fine, even athletic activities. Sometimes we ask a patient to wear a binder just to kind of keep the pump a little bit more in place. But for the most part, people can remain very active. We don't encourage hot things like hot tubs or some of those heat packs directly onto the pump, because we're worried about this accelerated flow. But for the most part, people can have a very active lifestyle. Contact sports become a bit problematic because we worry there's not really much that can happen, but it can be quite painful if you're hit directly into the pump. As I mentioned, hot tubs or saunas are discouraged. I tend to tell my patients, definitely not when the chemo's flowing. Once there's no chemo, because the way that we give the treatment is we give 2 weeks of chemo and then we give the liver a break for 2 weeks. When there's no chemo in there, I'm a little bit more lenient. We also don't want to accelerate the flow of the saline. It's just like a saline solution or a glycerin solution to lubricate the catheter. But we can accelerate it a little bit, and it's not it's not as big a deal as when the chemo's in. But you know, some people say don't do it at all, but I think it's in conversation with the patient, as long as they know when the chemo is flowing and when it's not, we don't need to be 100% as strict at all times. And then we worry a little bit about changes in elevation for extended periods of time. This is really not so much of an issue for most people. Sometimes high altitude for people living, you know, in the Rocky Mountains, we worry that it can accelerate the flow a little bit, or long flights that are over 8 hours might accelerate the flow. So I often tell my patients, not ideal to travel if the pump has chemotherapy in it, if it has FUDR in it, but if it's just a flush, then it's like I said, it's not such a big deal to accelerate it a little bit. So we do give people, just like with the Metaport, we give people a letter to say, look, I have this, you know, titanium pump in my body, so that it's not a huge deal at the airport security. As we all know, it can be kind of a nightmare these days. So that's, you know, that's an important thing to have along with a Metaport letter. And then during treatment, for the most part, we do see our patients every 2 weeks. The chemo is given every other time. We monitor liver function tests really closely. As I mentioned, the pump can certainly kind of, you know, overstimulate the liver sometimes, and there can definitely be liver inflammation. And the way that we give the chemotherapy very much matters on how much liver inflammation there is. So we have to look at the liver function test, which is a blood test looking at what the liver enzymes look like when the pump is filled and when it's emptied of the drug each time, because we have these very strict calculations that we use depending on the elevation of any number of those liver function tests. So, you know, we're pretty strict about that. Once treatment ends, it tends to be easier. We don't need to do as active maintenance. We have what we call glycerol, which is like glycerin medical grade, and it's just gooier. It's instilled into the pump and it flows much more slowly. And so if a patient is not getting active pump chemotherapy, we can fill the pump with glycerin, and then we have about 6 to 8 weeks until we need to fill it. So patients are less tied to us, so to speak, when they're not, you know, necessarily on active pump therapy when we're doing pump flushes, which is always nice for people to get a break from us. So this is a patient testimonial that I'll just read to you, but this is Rick. He was diagnosed with intrahepatic cholangiocarcinoma. So he was receiving aggressive systemic therapy for about a year, but his tumor was stable. It wasn't shrinking, and unfortunately surgery was not an option. So then he learned about HAI, or pump therapy, had a pump implanted, and then began treatment with HAI therapy. And after a year, he had enough of a response that he was able to get a resection. And he's been doing great since that time, which is always amazing to see. And you know, obviously this is the dream story. But as I mentioned, I think even with a good response, and if patients can't get to surgery because sometimes the tumor just scars over, we do see this sort of, you know, quiescence, like that the tumor is just kind of quiet and not changing and not growing and not affecting the patient's liver function, which is you know, quite beneficial too. And as you saw, patients can live for a long time that way, which without a resection as well. So I'm happy to take questions. I do have some questions that I could prompt, or if there's any questions, maybe I'll stop and see. Happy to chat.
If anyone has any questions, please feel free to put them in the Q&A or the chat. Is it true that once the pump is out, it cannot be put back in?
So that is a great question. It is true. So what happens is the way that the pump is put in is it's sutured into an artery. And so when the pump, if we take it out, the way that we remove it, the surgeons remove it, is they actually take out the pump from the pocket underneath the skin, but they leave the catheter in the abdominal cavity. And then what happens with that catheter is it fills up with blood and it clots over. It's not dangerous to the person in any way, but then we can't go back in and connect it. We've had some cases where the pump might get infected and the surgeons can quickly save it and put it into the other side of the abdomen. So in that sense, it can happen. But once the decision is made to stop pump therapy or the pump is taken out, it can't be put back in.
How long is a typical treatment period?
Very variable. I would say it's open-ended. I think most patients, it's a number of months. We really continue to treat until we are limited because of liver inflammation or some other type of toxicity potentially, or we are done because the response has been good enough, like in Rick's case that I mentioned, and the patient can undergo surgery. If there is continued response, the patient's doing well, then it's kind of continued therapy. So the way that our trial is designed, for instance, it's just, continuation until any of those occur.
Okay. Are there other drug combos besides GemOx that can be given through the pump?
Very good question. So so into the pump, and I should have clarified this better, into the pump, we give a drug called FUDR. It's called floxuridine. That's the drug that goes into the pump. The gemcitabine and oxaliplatin are given in addition through the vein. So the FUDR is the drug that's processed very quickly by the liver. Other drugs have been studied, but it just doesn't work as well. We looked at drugs like 5-FU, oxaliplatin, some of them are more common drugs that we use in cholangiocarcinoma as well as in colorectal cancer. But the dosing couldn't be as high as it is with the FUDR or floxuridine. And so we've really stuck to floxuridine as the drug of choice. And the study that was done that I mentioned was with FUDR, and as well as the study that's currently ongoing is with FUDR into the pump. We are very hopeful that we're going to, develop and work with companies to find other drugs that I think will be beneficial, especially now that more and more centers are using liver-directed therapy with the pump. I think that's, very exciting and always of interest, right, to companies. If there's more interest, there's a worldwide interest now. So I think we're definitely going to find, other drugs that can be administered the same way, that are also cleared by a similar mechanism, and test those in clinical trials in the future.
How is HAI different from Y90, and what would cause you to choose one over the other?
So HAI is a pump with chemotherapy, floxuridine directly into the liver, and floxuridine is known to be, toxic and to kill cholangiocarcinoma, adenocarcinomas, colorectal adenocarcinoma, et cetera. Y90, the way that it works is there are small little radio-labeled beads that are placed into the liver through almost like through the groin, through an artery that's accessed through the groin, kind of like a cardiac catheterization, like a cardiac cath, except instead of them going up to the heart, they make a left turn and go to the liver. And using a CT guided imaging, they find the liver tumors, the cholangio tumors, and instill radio-labeled beads. And how many depends, it's a whole calculation that the interventional radiologists do. And then these radio-labeled beads emit radiation sort of internally and kill the tumor that way. And so it's a different approach. We at Memorial use pumps much more. We do have a very active Y90 program as well. But we tend to start with pumps, and then if there's growth in the pumps, and this is cholangio and colon and as well, then we might go to use Y90. There was actually a study done in cholangiocarcinoma with Y90 that also showed a similar efficacy in terms of control of primary tumor growth, which was nice, but there was more toxicity, and the survival was not as good. And what, we couldn't tell if it was due to necessarily potentially other lines of therapy that were not able to, the patients weren't able to receive because of the difference in the toxicity profile. But I think the short answer is it's, we very much believe in pump therapy. Other centers are much more familiar with Y90 and are doing that and are studying that actively in cholangiocarcinoma also.
Is this therapy for non-surgical options?
Yes, we give this therapy for non-surgical liver limited disease. Where we wouldn't use it is in patients who have cholangiocarcinoma involving the liver, but it's also spread to the peritoneum or the abdominal cavity. That becomes much more difficult and challenging to treat, and we don't want to focus just on the liver if there's a disease in the abdominal cavity, or extensive disease in the lungs or something like that. So it's really for patients that are limited to the liver, but they can have multiple sites in the liver. It doesn't just have to be, one single tumor in the liver.
So I guess to follow with the Y90 HAI, if there's positive regional lymph nodes, but it's not resectable, is that something that HAI would be applicable for, or?
Yes, fantastic question. I appreciate you pointing that out. I should have mentioned that. Yes, it is even if there's regional lymph nodes, what happens is when the pump is put in, the regional lymph nodes are removed surgically. So often the surgeons, as I had mentioned, don't remove, the liver lesions in the cholangiocarcinoma, but they do remove the regional lymph nodes. In our trial that we published, the phase 2 study, we actually looked at outcomes in our patients who had no regional lymph nodes, or those who did have regional lymph nodes that were resected at the time of pump placement, and there was no difference in survival, which was actually very encouraging for us to see. So absolutely, people with regional nodes are eligible.
That's good to know. How does one become a candidate for the HAI therapy? Where are you located? I
So
guess
we
these
have,
two questions are similar.
yeah, that's a great, there are now a number of centers, and I apologize for not having a map, but there's a number of centers in the US that are now doing HAI therapy, and surgeons that are placing HAI pumps. So we certainly have, as I mentioned, the program and the trial open at MSK. Our studies also open at Duke, WashU, and the NCI, but there are a number of other centers that are putting in pumps as well. Not all of them may be doing it for cholangiocarcinoma. Some may be limited to just colorectal, but that's definitely something that that is expanding. And if there's any questions, we're happy to answer and help direct people if throughout the United States, if we can help. Let me know.
Okay. What would exclude one from being a candidate for getting the pump?
So aside from having metastatic disease outside of the liver, rarely anatomy does exclude. The patient, there's a small percentage of people that don't have the correct vascular supply, just naturally the way that they're born. There's sort of a different variation in the blood vessel supply to the liver, so that sometimes precludes patients from having a pump. It's rare, but it can happen. And other than that, it would really be, for the most part, metastatic disease. Potentially, if the patient has a cirrhotic liver, liver failure, that may be an issue as well. If we determine that the liver is not working well because of the actual tumor, then it's not exclusion criteria.
So what if you live 4 hours away and the pump malfunctions? What is protocol? Can the local oncology team assist with troubleshooting?
Yes, it depends on the malfunction. It does happen. What we try to do is we try to find local teams that are slightly closer to our patients, and that know how to access the pump and know how to troubleshoot. Or we say, go to the local emergency room, and we kind of get on the phone and help troubleshoot. And if it's a major issue, then we bring our patients in.
Can HAI be used after first-line chemo, a tear, and TIPSOVO failure?
Yes, after first-line chemo, the TIPS failure most likely, but it depends a little bit on the liver anatomy and the state of the liver, the functional state of the liver.
Okay. Is the pump MR limited?
You can get an MRI with the pump.
Okay. Is the GEM-OX for systemic use consistent for this across Sloan and the gallbladder too? I don't know.
We do GemOx with the pump. Without the pump, we do GemCis, and we're discussing potentially using cis instead of oxaliplatin on the trial. We believe that they're equivalent based on data and based on our experience, but for interpretation, in the future of the study results, as I mentioned, it's going to be opening in Europe, where they're much more strict about the flexibility of which drugs they can use systemically. So that's something that we're working on. But if there is systemic disease or for systemic chemotherapy, we tend to use more cisplatin than oxaliplatin.
Okay. Is this available for perihilar cholangiocarcinoma?
It's not. We tend to stick more to intrahepatic just because of where the pump works best.
And just for the community, for those who are interested in where it's available, we do have a link, and we can put that with the recording afterwards. So we'll send it out so that people have that. Is this done in Canada? The HAI pump, do you know?
Yes, there is one center in Canada that does it.
Do you happen to know which one it is?
I will look it up as we speak.
That's okay. So, and then we have questions of whether it's available in Europe, Greece specifically.
Not yet. Not yet in Greece, but it's available for now. It's available in the Netherlands at actually 3 centers, believe it or not, in the Netherlands. They have just been super happy with their results, and they happen to have a lot of cholangiocarcinoma there, surprisingly. And in other parts of Scandinavia, they are working on it. So not yet. And I believe in Israel, they're starting a pump program as well. And there's some talks in Ireland, but it has not started yet.
Okay, well, that's good news that there's talks at least. Could HAI work in parallel with PTC drainage?
Maybe. Usually we usually only do it if the liver does not have any damage. If the drainage is needed, let's say to decompress the liver to start treatment, sometimes with the pumps we can start treatment and see if the response from the pump is good enough so that the patient may not need a drain. Often with cholangiocarcinoma, patients do, and or a stent. So we would do it if the drain is needed from liver because there was liver damage or liver toxicity that's not disease related. That would be, I think we would have reservation with that because we would worry about causing more damage by adding this high dose chemotherapy, into the mix.
Okay. Does tumor vascular encasement affect the ability to get this treatment?
It shouldn't, as long as the pump can go in.
Okay. If you go in to place the pump, would you take the regional nodes and the gallbladder out?
Oh, yes. Good question. The gallbladder does come out. So yes, the surgeons take out the regional nodes, and they always take out the gallbladder when the pump is placed because, and this was years ago, we found that if the gallbladder is in place, when we give this high dose of chemo, it preferentially kind of goes through the arteries, as I mentioned, and then into the biliary tree, and then goes right into the gallbladder. And before we took it out, patients used to get actually gallbladder inflammation and cholecystitis, and it was a big issue. And so now everyone has their gallbladder removed at the same time as they get their pump placed.
If you have scar tissue in the liver, can you still use the pump?
Yes, as long as the pump can go in and there's no, significant damage, you can.
Okay. Do you know if there's a cost associated with this?
There is. There definitely is. I don't know the price off the top of my head, but there's obviously insurance companies do cover it. We have not had any issues with that. But there's a fee, of course, of getting the procedure, the surgical procedure, and then the pump, and then getting the chemo administered tends to be the same once the patient is cleared for the chemo administration. But the patients should not have to pay for this out of pocket. This should be covered by insurance.
Okay. Do you see patients currently receiving treatment elsewhere?
Would you mind repeating that?
Do you see patients currently receiving treatment elsewhere?
I do sometimes share patients. The cholangiocarcinoma a bit less so, I would say. Most patients stay. As I mentioned, we do it a lot in colorectal, so we do see patients elsewhere. But many of our patients, can sometimes travel from far and come see us twice a week for this treatment. And I have an answer to the Canada question. It's Sunnybrook, and I apologize that I blanked on that. I feel badly, but they're doing it just for colorectal for now, not cholangio yet.
Okay, that's good to know. Thank you. With the HAI, can radiation be utilized, or is it just utilizing chemo drugs specifically for the liver?
So we do radiation, not at the same time. That would be too toxic, and our hope would obviously be that the pump would do enough. So it's a little bit different than systemic plus radiation in that way. What we've done sometimes is if, let's say there's a mixed response and a tumor grows, we might consider radiation or ablation to that particular tumor. But not, I know many centers do, radiation as part of the sort of protocol of cholangiocarcinoma treatment. We do much less of that because we have the pump.
Okay. If the tumor is not vascularized, would a patient still benefit from the pump?
Yes, the cholangiocarcinoma always is very vascular. Other tumors, if that's the question, definitely less so, and we've looked at that too, but not with cholangiocarcinoma, definitely.
Okay. Can the pump placement always be performed with robot surgery? This will let the patient recover more quickly post-operatively since no liver resection is performed.
They do it with one of our surgeons, not all. Most of them still do open surgery. They do laparoscopic. So, but not robot. It's yeah, it's the laparoscopic is definitely a faster recovery. But I don't think they're quite there yet in terms of the all the nuances to have it be totally laparoscopic at all times.
Okay. What negative effect does the pump have on the bile ducts and other parts of the liver?
So what happens with it is that because it's such a high dose of chemotherapy and it, as I mentioned, it goes to the tumors, but it also goes to all the healthy cells in the bile ducts. It can cause inflammation. And sometimes, particularly in the bile ducts, that inflammation doesn't always go away or it doesn't heal, and then it can cause scarring. And so what it can lead to is something like a biliary stricture, almost like biliary sclerosis, because the inflammation didn't go down. And so sometimes people need stents after liver-directed therapy, after pump therapy, because of the damage from the FUDR, from the high-dose chemo. Okay. It's under 10%, but it can happen at about 10%.
How common is ablation and who are good candidates?
I like ablation. I think it depends, I think it depends on what you can accomplish with it. So typically for ablation of the liver, so it's radiofrequency ablation that we do most often. It's not very common for cholangiocarcinoma because the problem is usually either there's a central tumor or it's large and we can't do ablation. If, for instance, there is what we call a satellite lesion, so you have the liver, you have the central tumor, and then there's a small 1.5 centimeter tumor on the periphery of the liver that may not be responding, or let's say is growing slightly, then that might be a good option to radiate that tumor. But it's really more considered like spot treatment, I would say, sort of like troubleshooting, and not as a definitive therapy.
Okay. Can the pump be used in patients with gallbladder cancer?
No.
Is there a benefit for utilizing the HAI for lesions in the liver while some small lesions were discovered in the abdominal cavity?
So that's usually the hard answer, unfortunately, to that is no, because when we find those lesions in the abdomen, the concern is always that the disease is outside of the liver, much more what we call systemic and much more likely to show up somewhere else. And so then we don't want to really focus so much on the liver if we know that we're going to have to change therapies or, advanced therapies potentially because of the disease outside of the liver.
Okay. Can you clarify the treatment regimen? They thought they heard you say that you receive a drug for 2 weeks and receive a 2-week rest. But then
Yes. So,
they
yeah.
heard that they have to be seen every 2 weeks for drug infusion. Can you just clarify that, please?
Yeah. So the way that it works is you come in, let's say day 1, and you're going to start liver therapy plus usually, as I mentioned, we give IV therapy. So you have chemo put directly into the pump. There's nothing sticking out of you. It's like a syringe that instills the chemo that's combined with some steroid, a little bit of steroid and some saline. And then you receive IV chemotherapy. And then for 2 weeks, you're not hooked up to anything, but there is chemo in the pump in the top chamber that's flowing continuously, the FUDR, into the liver. After 2 weeks, so then on day 15, you would come back to the oncologist, have your blood counts checked, including the liver function tests. The nurses would remove whatever fluid is remaining in the pump and put in just some saline into the liver to let the liver kind of cool off. But that day you would still get the IV chemotherapy. And then you go home and all that's flowing into the liver is saline. So your liver's relaxing a little bit. And then 2 weeks after that, you come back in for the next cycle of FUDR, of liver chemotherapy. So then the nurses take out whatever is remaining in the chamber. There's usually a few milliliters or cc's of saline, and then they put in chemo mixed with saline and a steroid and IV chemotherapy. And that happens every 2 weeks. And every time you come in, you get your liver numbers, your blood counts checked, just like you get a CBC for your white count, your platelets. We also check liver function at that time, every 2 weeks.
We have a couple of questions on how to become a patient for the HAI pump. What's the process?
If you like the easiest, I think, is you could reach out to MSK, to the GI oncology scheduling hotline, and we'd be happy to help, see if that's an option and how we can help. And if there's another site that's closer to your home, we can definitely help with that. They usually would reach out to me or one of my colleagues. I think that's probably the easiest way to do it.
Okay, perfect. Is this delivery option recommended for stage 4 patients or only those with local disease?
It would be for those with local disease that is connected, that is contained in the liver. So there can be multiple sites in the liver, but it's in the liver. And I think, another way that we could consider for patients, if you're interested, and Tara can help with that too, because they know which physicians are close by and which centers are actually either participating in the trial or treating cholangiocarcinoma patients. So that might be, even easier.
Okay. And I think this is just more clarification. Are you saying that patients receive injected chemotherapy at the same time as through the pump?
Correct. Either through a port or through an IV. Exactly.
Okay.
They don't have to. Just so I should clarify that actually, that the FUDR, the liver therapy, does work on its own as well. So, I was referring a lot to the study, but if, let's say, patients are not fit enough for systemic chemotherapy, too sick or don't want it, we do see responses, really nice responses with just the liver directed therapy alone. So that's definitely an option as well.
Okay. And then another clarifying question is, do you accept patients currently being treated by another oncologist receiving traditional chemo only?
Yes, we've had patients after, yeah.
Okay. I think we had all of the questions answered that were in the Q&A and chat. If anyone else has any questions, please send them along. There was one individual who asked if there was a treatment, if this was at Mass General, and the answer to that is yes. I saw David from Intera mention yes, so we have the answer to that. I don't think we have any other questions coming through. This was really great and informative. Thank you so much.
Thank you so much for having me. I really appreciate it.
Yeah. We will have this recording up by hopefully tomorrow. So if you want to rewatch the recording, we will have it up for everyone to be able to access that way as well. Do you happen to know who the contact is at NCI?
It's Jonathan Hernandez. We can maybe put in.
We have his information. He was
Yeah.
so we'll make sure to send that to this person. We'll make sure to have that information. Thank you, Jonathan Hernandez. Okay. Thank you so much. This was wonderful. We appreciate your time.
Thank you very much. Thanks, everybody.